we treat heart failure with preserved ejection fraction using a myeloperoxidase inhibitor that decreases inflammation? That's the question of this trial. My name is Barry Borlaug. I'm a professor of medicine and cardiologist at the Mayo Clinic in Rochester, Minnesota. We conducted an acute clinical trial of a drug which inhibits the enzyme myeloperoxidase called Myeloperoxidase at the Mayo Clinic in a single-center acute hemodynamic trial. Myeloperoxidase, as most of you know, is an enzyme that's present in neutrophils, and it's involved in the host immune response, allowing for elimination of pathogens that are trying to attack the body. It's also been shown that increased levels of myeloperoxidase lead to vascular inflammation and can scavenge nitric oxide, which decreases nitric oxide bioavailability, which we know is a big problem in HFpEF. Many patients with heart failure and preserved ejection fraction have reductions in nitric oxide availability, leading to the hypothesis that if we could interrupt this with an inhibitor of myeloperoxidase, potentially we could improve vascular function. One particular vascular bed that is affected in heart failure with preserved ejection fraction is the coronary microvascular bed. About 75% of patients with HFpEF have coronary microvascular dysfunction. So this was an important potential treatment target that we wanted to evaluate. So in this trial, we took 30 patients with HFpEF and randomized them 1-to-1 to mitapirstat or placebo. They underwent baseline hemodynamic exercise testing, so hemodynamic evaluation at rest and with 20-watt exercise. Then they were randomized double-blind to mitapirstat or placebo. We waited 30 minutes, and then we repeated the rest and exercise assessments. In addition to measuring the hemodynamics, including pulmonary capillary wedge pressure or left heart filling pressure, which was the primary endpoint, we also did transcardiac blood sampling. We cannulated the coronary sinus and measured concentration of various metabolites in the arterial and coronary sinus circulation, along with blood gases, to look for things like ischemia. The patients we enrolled were very typical of HFpEF, older aged, overweight or obese, predominantly women who had mildly elevated pressures at rest, which increased markedly during exercise. Contrary to our hypothesis, we did not find that mitapirstat favorably affected the pulmonary capillary wedge pressure during exercise. In fact, the pressure was somewhat higher after treatment with mitapirstat as compared to placebo. In both groups, it went down with the second bout of exercise, which is typical of what we see. There is a priming effect of exercising that leads to lower pressures with subsequent bouts of exercise. But that priming effect was lost with treatment with mitapirstat as compared to placebo. So we could not confirm our hypothesis that this would be this would lead to improvements in hemodynamics. There were also trends for less improvement in pulmonary artery pressure and pulmonary artery compliance. And when we looked at the transcardiac blood sampling, we saw no evidence of an effect on oxygen uptake or metabolite use in the heart. So overall, these findings do not support use of mitapirstat in patients with HFpEF, though we will have to acknowledge that this is a very small trial, a single center trial, and most importantly, it's only an acute trial. And we know that long-term effects of drugs often differ from what we see with acute effects. But based on our trial, this does not support this as being a potentially effective drug, though other larger multi-center trials are currently evaluating this as well. I'd like to invite you all to review the article and read it over and learn more about this somewhat disappointing but nonetheless important result that we found in our trial. Thank you very much.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel. www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.